First of all, congratulations. It's really remarkable what you guys have done, and Alexandra, led by you. I mean, amazing what you've accomplished in a really short time. And I'm going to get on and click, so we can get a very high impact factor. All right, so I'm going to whip through this, talking about breakthroughs in pulmonary embolism therapies, and these are my conflicts of interest, and Sahil's going to correct me if I'm wrong about anything here. He's supposed to be up here to correct me, but so this is a slide I just made, and it's not accurate, but it's not to scale, but it's kind of to scale. The data and evidence base in acute MI and stroke is massive, yet for pulmonary embolism, it should be even a much smaller dot. In terms of the comparison here, and you know, I think that that's remarkable given the fact that pulmonary embolism kills almost as many patients as stroke, and maybe as many as stroke. So we have a long way to go. But as in this letter to the editor, the honest letter to the non-believers of advanced PE therapy by Peter Monteleone, published in JSCAI. Thank you for doing that. This field is progressing faster than nearly any other has in clinical history. And I really think that, you know, the stage was set for high quality evidence development with this manuscript, an AHA scientific statement, not in JSCAI, but it's you know, by a very good cardiologist and who's a committed SCAI member, which is Jay Geary and his colleagues, where they set the stage. And so I'm just going to talk about a few different breakthroughs. Breakthrough number one, and this is the one that's most near and dear to my heart, which is that the impact of PERT has really been dramatic over the past 10 years since its inception. This article was published showing that pulmonary embolism response teams actually do improve outcomes, and this is just a summary of the data showing that patients who were evaluated by a PE team, a PERT team, had better outcomes. It's pure and simple. The only thing where they didn't differ was in 30-day readmissions, but they had more advanced therapy utilization. They had less less mortality and lower hospital length of stay and lower ICU stay. Interesting. So breakthrough number two, improving risk stratification. This is something we really need to do. This was published in JSCAI. It was a Mitch Silver article looking at it was done in preparation for one of the Peerless trials, actually, sponsored by Inari, and I think the idea was to look at the incidence, just get an overview of what the mortality and complications were in this high-risk pulmonary embolism group. And what was interesting is they found that there was really very high in hospital and 30-day mortality and bleeding and even intracranial hemorrhage. And in spite of all the progress in PE, this problem still exists for the high-risk group. So that brings us to another issue, which is how do we improve risk stratification? This is the risk stratification in current guidelines, which are really 10 years old or more. Can we do better? And the answer is yes. There's limitations in the current risk stratification, especially for the high-risk group, and it's time for the new categories to be thought through. This article was published, and this great work by Tai Kobayashi and his colleagues, looking at the contemporary management of outcomes with patients with high-risk PE, and they brought up the concept of catastrophic risk, which is really novel, and you know, it sort of makes sense. We all know it. When you see a quote high-risk patient, some of them are really high risk and some of them are not really that high risk, but they're all categorized that way. They need to be subcategorized. And so they did a study where they looked at, used the PERT Consortium Registry. This is the largest cohort of PE patients ever, and it's way largest cohort of high-risk PE patients. Nobody has ever come even close to this. It's all less than 100 patients with high-risk PE. This is 1,400 patients with high-risk PE, and 197 of them had some form of hemodynamic collapse, and they were categorized as the catastrophic group, as opposed to the 1,245 who didn't. And you can see that the use of advanced therapy, well, this is the intermediate risk, all high-risk patients, and on the right here, no difference between the catastrophic and the non-catastrophic, but the outcomes were quite different. And let's see, I'll get to that in a second, but ECMO was used more in the catastrophic risk, in the catastrophic group, 13%. Catheter-based therapies were basically higher in the non-catastrophic group, interestingly, because more of the catastrophic group were thought to be too high risk to bring to the OR or to the cath lab, so they ended up getting thrombolytic therapy in many instances. Systemic thrombolysis was higher. Overall advanced therapies were equal. But the mortality was quite different, and you can see the catastrophic high risk was much higher. They did a multivariable regression analysis, and this will help constitute for us, and I'm not going to go into the details here, but it will help constitute for us what will be new risk stratification. And as we learn more about this highest risk, we'll change the tools we use to stratify risk. We'll develop new tools. It'll change our therapeutic decision-making. Use of ECMO might go up, and to temporize patients and stabilize them, and the choice of device, surgical therapy, and so on will change. And so that, there's a paradigm shift that's happening, which is, if a patient's in the catastrophic risk group, you got to ask yourself, should I stabilize them with ECMO? It's much like Impella in the cath lab. Should we put an Impella in to make sure they're going to survive this whatever intervention I'm going to give them? So breakthrough number 3, there's more data coming on intermediate high-risk patients, and this is the Peerless randomized trial that was published recently, not in JSCAI, but its heart's in JSCAI. And this is compared mechanical thrombectomy to catheter-directed thrombectomy, and it based its outcome on the win ratio, which was a novel approach to, as I think all of you know, novel approach to looking at outcomes, and essentially found that mechanical thrombectomy kind of won the battle, if you want to say that, but it was based mostly on this the length of ICU stay. There was a slight difference of bailout, a little higher bailout in the catheter-directed lysis group. But I think this is a novel approach to looking at outcomes, and it's the beginning of randomized clinical trials. There's also another trial that came out, the rescue trial, that looked at there was a single-arm trial looking at the Bashir catheter for lysing thrombus in the pulmonary artery. And the reason I brought this trial up is because they did very good analysis of the amount of clot that was obstructive and how much of that was lysed and whether that made a difference. And in this case, they had significant reduction of pulmonary artery obstruction, more than any other therapy to date. I think this kind of sub-analysis is going to be really important as we figure out how to improve outcomes to the next step in pulmonary embolism therapy. So I just bring it up and in fact, they did this very in-depth analysis looking at the amount of clot in each of the segments. We don't have that yet in most studies, but I think that might be the future of pulmonary embolism analytics. So the drumbeat continues in favor of advanced therapies. That's another, I guess, breakthrough. There's increasing data supporting thrombus removal by whatever means, as opposed to conservative therapy with anticoagulation. And the adoptions for devices are expanding. This was published in JSCAI, and it was an analysis of the APEX trial, which is an angiodynamics trial, showing that this device, the AlphaVac catheter, had similar results to reduction of mean pulmonary artery pressure, reduction to modified Miller index score, and improved RV-LV ratios. It's a kind of a Me Too trial, but it was done in an incredibly rapid time and published in JSCAI, and you can see that they actually had further reduction in clot burden, even more so than some of the other trials to date. So there are many IDE trials that are coming down the pike. These are single-arm studies looking at different devices, the Symphony, the Symphony catheter, the Gulf trial, the Aventis trial, which just completed its enrollment and actually submitted to the FDA, I believe. The Acura trial, which is getting going, the Laguna thrombectomy trust trial, and Sperari, which is underway with about 30 patients enrolled. So these are all, trying to get them to enroll, going to try to get them to submit to JSCAI. All right, we got to go. So So I think the most important thing, groundbreaking things, is that this is a slide from Jay Geary. I borrowed a few of his slides, and he described the beginning of the golden era of randomized trials in pulmonary embolism, and I think that's really what's happening now. There are now 7 prospective randomized trials, and I won't go through them all, but they're all going to be groundbreaking. They're going to define the therapy, and we need to be here, and hopefully some of these we'll be able to direct to the journal. One of them I'm the PI of, which is a high python trial, which is looking at thrombolytic therapy, catheter-directed thrombolysis with the ecosystem versus anticoagulation alone. And I'll just suffice it to say we're almost finished with enrollment. We'll probably finish by June. And this trial was interesting because it didn't take just intermediate risk patients, intermediate high risk. It's intermediate high risk that are enriched to try to really find, the so-called orange patients, orange category patients who really we're not sure if they're going to do okay on anticoagulation alone, and there's equipoise therefore to randomize them, which is a novel approach as well. Peerless 2 was published, is underway now. This is also randomizing between, in this case, large bore thrombectomy versus anticoagulation alone. And I understand they're doing a pretty good job with enrollment already, 1,200 patients. So there are new AHA guidelines coming. That's going to be disruptive and groundbreaking. Stay tuned. I don't know what they say. I wasn't on the writing committee, but I understand it's going to be quite interesting, and it's going to address some of the risk stratification that I described before. It's exciting times for pulmonary embolism. If you're interested in PE at all, even if you're not, you should come to our 11th annual meeting of the PE, the Pulmonary Embolism Consortium, which is going to be in San Diego. And, some of the stuff that's happening is going to make a difference and impact. We have a quality registry that has now got over 15,000 patients. It's been changed over to MCORE now, and we're ramping up the version 2 of the registry. The database there's 300 hospitals that are interested in the database. There's 300 hospitals are also interested in our Centers of Excellence program, which is really going to upgrade the care for pulmonary embolism around the country and the world. So thank you for the opportunity to talk today.
Thank you so much.